5. Stimulus hypersensitivity. Fear is a stimulus-driven aversive response to an external or internal cue that is perceived as a potential threat. However, in clinical states, fear is elicited by a wider range of stimuli or situations of relatively mild threat intensity that would be perceived as innocuous to the non-fearful individual. For example, most people would be quite fearful about approaching a Sydney funnel web spider, which has the most lethal spider venom in the world for humans. On the other hand, a spider-phobic patient was referred to our clinical practice who exhibited intense anxiety, even panic attacks at the sight of a spider web produced by the smallest, most harmless Canadian household spider. Clearly, the number of spider-related stimuli that elicits a fear response in the phobic individual is far greater than the spider-related stimuli that would elicit fear in the non-phobic individual. In the same way, individuals with an anxiety disorder would interpret a broader range of situations as threatening compared to individuals without an anxiety disorder. Anxiety and the problem of comorbidity. Over the last several decades, clinical research on anxiety has recognized that the older term anxiety neurosis had limited heuristic value. Most theories and research on anxiety now recognize that there are a number of specific subtypes of anxiety that cluster under the rubric anxiety disorders. Even though these more specific anxiety disorders share some common features such as the activation of fear in order to detect and avoid threat, there are important differences with implications for treatment. Thus, the present volume, like most contemporary perspectives, will focus on specific anxiety disorders rather than treat clinical anxiety as a single homogeneous entity. Psychiatric classification systems like DSM-4 assume that mental disorders like anxiety consist of more specific disorder subtypes with diagnostic boundaries that sharply demarcate one type of disorder from another. However, a large body of epidemiological, diagnostic, and symptom-based research has challenged this categorical approach to psychiatric nosology, offering much stronger evidence for the dimensional nature of psychiatric disorders like anxiety and depression. One of the strongest challenges to the categorical perspective is the evidence of extensive symptom and disorder comorbidity in both anxiety and depression, that is, the cross-sectional co-occurrence of one or more disorders in the same individual. Only 21% of respondents with a lifetime history of disorder had only one disorder in the National Comorbidity Survey, a National Institute of Mental Health epidemiological study of mental disorders involving a randomized nationally representative sample of 8,098 Americans who were administered the structured clinical interview for DSM-3R. Based on a sample of 1,694 outpatients from the Philadelphia Center for Cognitive Therapy evaluated between January 1986 and October 1992, only 10.5% of those with a primary mood disorder and 17.8% with a panic disorder with or without agoraphobia avoidance had a pure diagnosis without excess 1 or 2 comorbidity. Clearly then, diagnostic comorbidity is the norm rather than the exception, with prognostic comorbidity in which one disorder predisposes an individual to the development of other disorders also important to consider in the pathogenesis of psychiatric conditions. Numerous clinical studies have reported a high rate diagnostic comorbidity within the anxiety disorders. For example, a large outpatient study found that 2/3 of anxiety disorder patients had another current axis 1 disorder and over 3/4 had a lifetime comorbid diagnosis. Individuals with an anxiety disorder then are much more likely to have at least one or more additional disorders than would be expected by chance. Comorbid depression. Anxiety disorders are more likely to co-occur with some disorders than with others. Much of the research on comorbidity has focused on the relationship between anxiety and depression. Approximately 55% of patients with an anxiety or depressive disorder will leave at least one additional anxiety or depressive disorder, and this rate jumps to 76% when considering lifetime diagnosis. In the epidemiological catchment area, ECA study individuals with a major depression were 9 to 19 times more likely to have a coexisting anxiety disorder than individuals without major depression. 51% of anxiety disorder cases in NCS had major depressive disorder, and this increased to 58% for lifetime diagnosis. Moreover, anxiety disorders are more likely to precede depressive disorders than the reverse, although the strength of the sequential association does vary across specific anxiety disorders. Results from the ECA survey waves indicated that simple phobia, obsessive-compulsive disorder, agoraphobia, and panic attacks were associated with increased risk for major depression 12 months later. Research into comorbidity has important clinical implications for the treatment for all psychological disorders. Clinical depression comorbid with an anxiety disorder is associated with a more persistent course of disturbance, greater symptom severity, and greater functional impairment or disability.